course, I've been excited about all of them, but this panel is going to be on the topic of emerging patterns nationwide in health information sharing. And we are both pleased and honored to have with us three national leaders in nationwide information sharing efforts. To my immediate right is Dave Cassel, the Director of Care Equality. He will speak first and tell you what Care Equality is all about. To Dave's right is Jitin Asnaani. Jitin is the Chief Executive Officer of the Commonwealth Health Alliance, and he will explain what that is all about. And to Jitin's right is Seib, the Chief Executive Officer for the National Association for Trusted Exchange, also known as NATE. And after these three leaders present, I'll have one slide to talk about some new use cases we've been discussing. Thank you.
Well, thanks, Jeff. My name is Dave Cassel. As you see there, I got the little jolt when we were advancing the slides prematurely there in the last panel. It's always a little odd to suddenly unexpectedly see your name up on a big screen, but it's great to be here, and thanks to the MiHIN folks for the invite. So we'll be talking, as Jeff said, about trends generally and patterns emerging in the national landscape in terms of health information exchange. I'll kick things off talking about those things in the context of my initiative, Care Equality, and sort of tee things up as best I can for Jitin and Aaron as well. So to start off, what is Care Equality? I'll answer that by talking a little bit about the current situation first. What we see nationally today, literally what's out there on the ground, is a number of communities, many communities in fact, defined very generally, that have come together to share information because they have some sort of affinity with one another. That may be geographical, that may be that they share an EHR vendor, that may be that they are patient-focused. You know, there can be communities of patients that use personal health records or the like. However they are formed, though, these communities come together and they form data sharing arrangements within that community to meet that community's needs. And that's what you see today nationally as the reality on the ground. There are many of these data sharing networks, programs, and initiatives out there. The challenge that they have, well, they have a number of challenges, obviously, in terms of meeting the needs of their constituents. But the challenge that they have with relationship to one another is that there isn't any systematic way for them to connect their members and participants to one another. Essentially, if you want to be connected to the participants of another community's data sharing program, you need to go join that community's data sharing program. It's a bit like having a cell phone that can only call other Verizon customers or other AT&T customers. What Care Equality is aiming to do is basically do for health IT and these data sharing programs what the telecom industry has been able to do for the cell phone networks by creating a standardized national level interoperability framework that links all of these communities together. Ultimately creating a web of interconnected communities for those common use cases that all the communities share. There is always going to be value, innovation that the communities are doing within themselves. They came together in the first place because they have unique needs typically. And there are things that their data sharing programs and networks offer the communities that are not necessary, don't necessarily translate to the other initiatives, but there are common sets of use cases for which we want to communicate between and among all of these efforts on a national basis. There we go. So Care Equality is not one of these data sharing programs itself. We are not competitive with existing efforts that are out there. Rather, we see ourselves as adding value to their set of services by allowing them to connect, again, for these common use cases, into a much broader ecosystem. In forming all of the work products, the implementation guides, everything that actually goes into the guts of making this happen, we do have a public-private, broad stakeholder participative process. We actively bring Lots of different stakeholders to the table. You don't have to be a member in our initiative necessarily. We actively recruit folks who are not members at times when we need a stakeholder perspective at the table. But we want to make sure that everything is really representing the broad community of healthcare in all that we do. So what I alluded a little bit to implementation guides and the guts of the details. What does it actually mean to connect these various data sharing communities together? The way we see it, and obviously this is a somewhat simplified view, there's basically three elements that go into making this happen. The first, and arguably most important, although they're all necessary, is a set of common rules of the road, a governance framework such that everyone who's a participant in the ecosystem at any level understands their rights and obligations, understands that those are the same rights and obligations that the other participants have, and that all of this has a contractual and legal backing so that they can rely on it. There was discussion in the last group at length about trust and the concept as it relates to a learning health system. Trust is essential here as well. And we got all of these broad stakeholders together as I was describing, and we were talking at length about trust when it comes to an ecosystem like we're talking about here, and the conclusion we came to is there simply is no natural basis of trust. Folks aren't going to trust one another. At the end of the day, they're still going to look at one another and say, how do I know that your actions aren't going to get me sued? And therefore, we came to the conclusion quickly that the way to establish trust, ultimately you can have a lot of principles, and we do have principles of trust, but principles alone won't cut it. You do need to have this actual rules of the road, contractual framework that is defined. Having that structure is, again, critically important, but it alone doesn't solve the problem. You do also need to speak the same language, and that's where well-defined technical specs come into play. We do this for care equality in the form of what we call implementation guides for particular use cases. So care equality at its heart is that governance framework, but once you have that framework in place, you can hang different technical use cases off of it. And right now, I'll talk a little bit more about this. We're rolling out our first use case under this governance framework for query-based document exchange, sort of the prototypical health information exchange use case where you request information from those who have it in the form of a clinical document, and you ideally receive it. The third element to actually make sense of the broad connectivity that you have through this ecosystem is a participant directory. It is essential, if you're going to have all of these different connections, that your systems have a way of understanding how to actually communicate at a technical level with all the other participants in the ecosystem. So having that directory to link it all together, it can sometimes feel like a little bit of an afterthought when you're in sort of the governance stage of things, but when you get into the actual operations, it's critically important. So who has actually signed on to that governance framework? Who has signed to that contract for the rules of the road? You see the set of folks there. There are many other organizations who are members of the Care Equality Initiative or who otherwise have participated in work groups and volunteered their time. But these are the currently 12 organizations, and there are others in the pipeline, but currently 12 organizations who have actually signed on to contractually implement connectivity with one another under those rules. They are a range of types of organizations. Some of them, as you see, are EHR vendors who can bring their customer base to the table. Some are HIEs who bring a geographically based community to the table. There are a couple of service providers in there that bring sort of a varied mix of players. And there also are a couple of PHR providers so that the patients themselves can directly participate in this community. And a little bit more on that as I talk about sort of what is coming here in the future. As promised, as we look at ahead a little bit and think about what's really, getting back to the big picture question of what are the patterns emerging in healthcare, I think the first one that I wanted to hit on is that it is really all about the patient. And you'll hear a little bit more on this from Aaron from his perspective at NATE. But we have to have patients engaged, and we want that to happen, but before that can happen, we need to make it easy. My sense is that that's a lot of the issue right now in terms of the struggle to get patients engaged in the way that we want is that we haven't made it easy for them. And I think what's ultimately going to be coming, and I'm not sure exactly what the form is that it's going to take or who are the lead players are going to be. We're going to do our part in trying to encourage this from care equality. But I think we need a revolution not unlike the Copernican revolution, where you had for the longest time this view of the universe as being centered on the Earth. And right now we have this view of information and healthcare being centered on a health system or on a provider or on a public health basis, maybe on a state. I think what we're going to get to ultimately, or need to get to, is something that is truly centered on the patient, not still patient-focused, but still ultimately centered on the health system, but truly centered on the patient, where the patient is controlling a lot of what is happening in terms of the flows of information, and they're able to do that easily. That being, again, the key. There's a lot of idealistic ways that you can think about making that happen, and you can talk about it as a policy goal, but ultimately you really need to do a lot of fundamental change in terms of how we think about health information in order to make that a reality. But that said, there's a lot of challenges there, but I do think that that's coming. Governance is essential. You hear a lot from ONC. Dr. Salvo didn't necessarily get into it today in her remarks, but in other forums and in general, you hear from ONC the need for governance, and that's where I see care equality fitting into the picture. As you look at APIs, for example, there's a lot of promise there, but they need to be standardized. There still needs to be a mechanism for trusting all of those who might be coming to the table, and you don't want to, if you can avoid it, do that on a one-off basis. And so that role of governance is important, and that's the area where care equality plays. Finally, the communities that I referenced are going to keep innovating, and that's essential. Meeting these national priorities is not something that can be done solely in a top-down sort of way. So all of the different data sharing programs that are out there serving their communities today are going to continue to innovate. They're going to continue to advance the ball. And I think we'll hear a bit from Jitin next on how his community around the Commonwealth Alliance is going about doing exactly that. So with that, I believe, there we go, turn it over to Jitin.
Good afternoon. Thanks again to MiHIN for inviting us here. We're really excited to be over here. It's actually, I can't believe it, but it's my first trip to Michigan. So I came a couple of days early and got a little bit of tour, a couple of towns nearby as well. So much so that I actually got here late yesterday. So sorry about that. Anyway, so as Dave pointed out, you've got a good sense of care equality, and Commonwealth is one specific network with a shared interest, a shared goal it happens to be nationwide. Specifically, what Commonwealth is. Oh, by the way, I should take one step back. My name is Jitin Asnaani. For those of you who see me around and don't know how to pronounce my name, it's Jitin. Sounds like kitten with a J. So, Commonwealth. Commonwealth is an independent, not-for-profit trade association. It's open to absolutely everybody, every organization, I should say, but it's primarily vendor-led, and I'll show you a little bit about who our members are in a moment. But we're really focused on a very simple vision, and that is, it's almost not even a vision, but more like a belief. And that belief is that wherever a patient goes, wherever a person goes, their data should follow them. So whether they're being taken care of by a provider in an ambulatory clinic or in a hospital, or by a home health person, by their teacher, by themselves, but whoever it is that is taking care of the individual, treating an individual, should not encounter the issue that they can't get the data on that patient for wherever else that patient has been. That's what Commonwealth is focused on. That's really the only thing that we're trying to make a reality nationwide today. A corollary to our belief, and it's really for practical reasons, we believe that access to that data should be built into whatever it is that a caregiver uses to take care of that patient. So it could be the EHR if that's what they use. It could be some sort of community portal if they use a community portal to take care of their patient population. It could be the LIS, the pharmacy information system. It could be an app, a drone. I don't know where healthcare will go. Betamax. Whatever it is that they use, for those of you who have kids and know who Betamax is, big furry robot. Whatever that presentation level is should have the data natively built into it, because if you create any distance between where you can get the data and at the point of time you're taking care of a patient, you're going to just not get the data. That's what happens today, right? Doctors just don't get the data if they have to take steps. It also just makes it really easy to scale, as I'll show you in a couple of slides. So that's what Commonwealth is. I almost forget to say this. When organizations join Commonwealth, they're doing so and agreeing that they're going to make availability to Commonwealth at a reasonable cost. That's about as far as I can go without going into some serious anti-competitive issues. So that's just a part of what they agree to when they join Commonwealth. So who are the organizations who are part of us? Right now we have about 50 members. You can see who they are over here, the founding members, and then the members who have committed to deploying services, and other members who are interested and eventually will probably deploy services as well. And I'll explain in a moment what I mean by deploy services. But our members account for, according to KLAS anyway, they account for about 72% of the acute EHR installations out there and 37% of the ambulatory EHRs. But what's funny is that they actually EHRs are actually less than half of our membership. Our members are across the care continuum. We have home health providers, skilled nursing facility healthcare provider, health IT providers, ambulances, patient portals, patient apps. It's hard to even keep track of all of these across the whole continuum. I learn something new every time a new member joins us, which is roughly every 2 weeks or so. So these are the members of the Alliance. You can see MiHIN is a member of the Alliance, so is THSA, so is the Delaware Health Information Network. They're helping us to try to figure out how do we make an impact to the charters and missions of those organizations in a way that's helpful and productive for their communities. So I said that we were trying to solve a problem. I used a provider example to demonstrate that problem, although it really applies to any sort of caregiver. But most of us are familiar with providers. Out of curiosity, how many people here are providers? Anybody here who is a practicing doctor? You got a handful? All right, okay, great. So as doctors, and certainly as patients, or for those unfortunate of you who've had to spend a bit of time with doctors, you know what the experience is like getting your data to a doctor. This is probably in the nicest way of saying it, actually. The typical experience is I have to ask my patients to remember something about their clinical history. In the worst case, I'm literally asking them to remember something like meds, which is a disaster waiting to happen. In the best case, I'm asking them something about where they've been, and that is replete with gaps and errors as well. And then at the end of that, I request a fax from the facility from which I want the data. That's the norm, and I know it's better now in some places than others, but that's still the norm across the industry. What we think really should be happening is a provider is empowered, or the caregiver, I should say, in this case I'm using again a provider as an example, but they're empowered from the get-go. I have a list, I have like a Google link list of all the places the patient's been, and I can do maybe a little bit of validation of the patient to make sure that I have the right places, that they've shared with me only the places they want me to see, but I'm starting in a position of knowledge, of credibility, where I know knows enough about my patient to actually seem like I know something about my patient, which, believe it or not, that's what patients want. And then I can get the data right there in the workflow. I can do everything in my EHR or in whatever system it is I use. It could be, the phone app, whatever it is that a provider uses or will use. They can actually know something about their patient in that context. And the way we do that is we've created a centralized infrastructure in the back end that enables organizations. Wow, my slides kind of got skewed up and down here. This is what happens when you build slides on a Mac and then you put it on a PC. There's, oddly enough, not enough interoperability in that industry either. The services we've built are really a centralized set of services that do things like enroll patients in our network, keep track of their list of locations where they've been. That's called record location for those who are not familiar. Figure out actually be able to create a unique identifier for them and link those records to that unique identifier. So in a very real sense, we have a national patient identifier. And then be able to query and retrieve data, because if you can do all those things, why not just make it easy to query and retrieve? And there are three characteristics of our architecture that are particularly interesting. The first of all is, like I said, it's a centralized set of services. What's interesting about those services, and like I said, I listed them on the right there, is that it does not actually store any of the clinical data. It's really just a really fancy router in the middle there that enables data to be queried from all the endpoints. The second distinguishing characteristic is that you will notice that there's only one interface from each of those purple dots to the center. I've put 8 purple dots here on a page just because that's simple to look at. In reality, it's thousands. And if each one had to connect to every other one or know how to connect to every other one so we can get data, even if you had something like a provider directory, which we don't because we don't need one, it turns out to be a tremendous pain. It turned out to be extremely unscalable. So in this case, every dot will always have just one connection to the centralized service and have access to everybody else on the network. And the third characteristic, which really doesn't come out as well on this slide, and I've always thought about maybe doing something to do about it, but it's the one I mentioned earlier, which is those purple dots. There's nothing in between those purple dots and the centralized service besides that interface. It's built in. The access to that data, to that central set of services is built in to whatever it is that the community hospital or the lab or the specialist or whatever it is that they use so that they can get access to the data. And more, as Jeff will explain, other types of bodies who are not represented over here but are very much key to the charters of states all across the US. What that looks like from a provider point of view, and I won't go, this is sort of our workflow, and I won't go through it sort of step by step, or at least not in tremendous detail. But there are a couple of things which happen for a patient to be enrolled, that's step one, for the data to be sent, that's step two, to the Commonwealth service in the back end, which sends back basically a list of locations and service dates so that a patient may verify that they've been to that hospital or they've been to that primary care doctor or they've not been to that physical therapist, or they just don't want to share or want to share data from each of those locations. And this entire process gets us to a place of being able to, at a much higher degree of fidelity, actually know where the patient has been and who they are without sharing any clinical data. No clinical data shared at this point. Only after they've actually made matches is clinical data shared. Now, I promised Tim when I came over here that I wouldn't just talk about all the great things Commonwealth does, but some of the things we've struggled as well. Some of them are common to everybody in Health Information Exchange, and some of them are unique. So we've created this process, and the feedback we've gotten from our providers that it's the right process, that these steps make a ton of sense. We've also gotten the feedback that it's a lot of steps. So we're working really hard on automation over the coming year to make these steps as automatic as possible. So the point, really what you want in healthcare is the ability to deliver insights at the point of care. I don't know if we'll get all the way there at the end of this year, but we're going to get a lot closer than any series of manual steps. The second thing that we struggle with that we've been addressing is, and it's come up several times over the last 2 days, is the CCDA. Everybody knows the CCDA has all sorts of gaps and holes and inconsistencies. What's funny about a functioning network is that you can't hide behind the standard and say that it just, that's the way that, it was designed by, whoever the poor designers are of the CCDA. And so, we can't interoperate. I don't have that luxury. So we are actively reconciling the CCDA, building in our what we think are the right solutions to it, engaging with HL7 and ONC and others such that we don't end up building our own island, because that's the last thing we want to do. Solving that problem of actually creating a valuable CCDA for our purpose, right? Our purpose is, that basically those same elements that are required in meaningful use, just make those actually available for the provider to use in ways that are truly meaningful. And the word meaningful has gone to heck now since Meaningful Use program came out, but you guys know what I mean. All right, so that's what the workflow is. Finally, where are we? So we are live in 4,500 sites basically across the US with another 3,500 sites signed. All of these sites are acute sites, ambulatory sites, and rehab facilities. Very shortly, we're going to have a number of skilled nursing facilities and home health facilities come up live. We announced that a couple of months ago, so I felt brazen enough to mention it here, even though they don't actually account for any of the dots on the screen as yet. And then we have a number of other sites which are probably going to be coming live over the course of the year: ambulance, care management, federal and state authorities, imaging, patient portals, patient apps, and I don't know what else. We have Apparently, the care continuum is a lot larger than any one man can imagine, and that's a good thing because it means patients go a lot of places for care, and all of those places deserve an opportunity to be able to treat the patient with the best care. So that's where we are. I guess if you can look real hard and count the number of dots in Michigan, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9. There are about 107 of them there. No, I knew that number before. There are 107 live sites in Michigan with another 55, I think, that are signed. So hopefully they'll go live this year or over the next few months. And that's over the last 7 months of being live, of being in mass deployment. So we still have a long way to go, but I'd say we've taken a good step so far. And that's it for Commonwealth. I will turn it over to our friends and Nate, who are, by the way, Commonwealth members, and we are members of them, to talk more about the patient.
Thank you, Jitin. I am excuse me. I am Aaron Seib. I want to tell you a little bit about Nate, but first I just wanted to thank these guys for their leadership, and they really have been working at this for 5 to 10 years. And what Nate has been working on is starting to become more emergent, and that's what Jeff asked me to talk a little bit about. And we're starting to see more and more entities and organizations looking at and becoming serious about sharing health information with consumers so that they can become better partners in their own care. Very quickly, a little bit about Nate. I've presented many times about Nate. I think most folks in Michigan are familiar with what we do. We're not-for-profit. We are open to all types of entities as far as government, non-government, public-private entities. In fact, here's a number of our members that includes commercial vendors. Very proud to say that Michigan is here, has been here with Nate for 3 years, and even before we became incorporated on May 1st, 2013. On the following slide, I show a couple of the folks that we collaborate with a lot. We collaborate often with our friends at Care Equality as well as Commonwealth. I think it's important that we look at the consumer as a beneficiary of all the things that we do and recognize, though, that it has to work first for the provider community and for the organizations that have to be sustainable in order to deliver care. I'm very, very excited as an indicator of the emerging trends to announce today. For those of you who are subscribers to Nate, you already know we have 15,000 entities and individuals that follow Nate. And we've made a press release today with the Undersecretary of Health for the Veterans Administration in concert with the ONC. And I really think that Dr. Shulkin nailed what the intent of Nate is. So I just thought I'd bring this slide up where he talks about enabling patients to take control over their health information and become informed and active partners in their overall health. So, you know, I get to stand on the shoulders of giants like Jitin and Dave Cassel and others and be able to hand data to consumers and get them more engaged in their care. And we wouldn't be able to do a tenth of what we do without the support and success of these guys. So I'm very grateful to them, as well as you know, Tim Pletcher, MiHIN, a number of our other regional HIE members and so forth. I thought I'd tell you a little bit about what we do, just to sort of talk about what the emerging trends are and where we see the next location where the puck is going to. So 3-4 years ago when Nate was founded, we started looking at the direct mode of exchange, and it's currently ubiquitous and deployed wherever there are CHIT technologies. So something like 97% of hospitals, 75% of ambulatory care facilities utilize direct, or have the capacity to utilize direct. And and I think it was Jeff's slide where he shows the catcher. We wanted to be able to complement that capability and enable consumers to catch their data from those who are using direct today. So part of what we've done, working with the community over 2 years, including consensus-based processes, working with state members, we were actually working with the VA as well, is set a minimum bar for entities that wanted to, or are, as we refer to them, consumer-controlled applications. So this slide demonstrates part of the emerging trend. In the first 6 months, we've brought on board, and what we have live is 8 consumer-controlled applications that are exchanging with all types of entities. Cerner subscribes to our trust bundle. A number of the commercial HISPs subscribe to our trust bundle. The VA will eventually be subscribing to our trust bundle and sharing via our trust bundle. The trend here that I see is the doubling in size of the number of consumer-controlled applications. There are at that point of maturity where they're looking at, you know, we're not building products anymore. We're actually ready to go to market. We are pre-revenue or becoming revenue generating, and I expect that to double every couple of years, if not more than double every couple of years. And that's an important part of Nate's mission, is to give consumers choice, because we think the applications that are ideal for people at different points in their life, and based on their different roles. I, as a family caregiver for an autistic child, have different needs and expectations than a woman who's delivering her first baby, or a veteran who's going through a prosthetic change. We think it's important that there's a competitive market that's diverse. So that's part of our mission, is to create a minimum bar that's sufficient for consumers to feel comfortable that their data is being exchanged. We have some requirements. We work with the FTC and others to make their privacy policies explicit, and other things that we do to help ensure that the technologies are secure, relying on the encryption channel that's created by direct messaging. I used to have to spend a lot of time on a slide like this explaining the difference between the regulatory environment that applies to docs and the regulatory environment that applies to consumer-controlled apps. And I think we're starting to see more and more people understand that. You know, Dr. DeSalvo talking about consumer-mediated exchange, and our friends from the OCR and others providing guidance to consumer-controlled applications on when does HIPAA apply to my application? Do FTC rules apply to my application? What does it mean that FTC applies to my application or my offering to consumers? So not to go into too much great detail here, nor to read the slide to you, but I think it's apparent to more and more folks in the country, and this is part of why we're seeing more and more adoption and more offerings, the consumer's right to access, which has always been part of HIPAA. Sometimes it helps to have an entity like the Office of Civil Rights spell out the applicability of this particular privacy rule, and how it helps ensure that when a provider discloses to a consumer via a direct address of their choice, their liability ends. So there's a number of guidances that have been produced. Be happy to go into a deep dive with folks. But the important thing to kind of take away that I think wasn't always clear was the fact that a provider organization has no obligation to investigate or determine the goodness of fit of an application chosen by a consumer. It's actually that consumer's right and responsibility to do that. And it's the obligation of the covered entities to share with the consumer in the way that they like. So just to, in recognition of time, I wanted to touch on a couple of things that we're working on now. We started working on direct, and now we see entities like the VA stepping up and trying to implement that at its scale. 9% of the population covered by veterans working towards using direct as a mechanism to push their data where they want it, including consumer-controlled apps that they chose. So we're looking again at 3 years from now, and we actually started probably a year ago with our friends at CMS working on a concept called Blue Button on Fire. Back then, Fire probably didn't have the name brand recognition, and I really encourage everyone who's starting to become interested in it to participate in tomorrow's course that's being led by MiHIN. Essentially, the concepts are related to APIs and applications that can interact with those APIs. And one of the important things over the last 10 months working with CMS and some of the other agencies that we've taken a look at is, Dr. Halamka actually put it pretty well about having enabling technologies in place. So folks who are really attuned to reading the CHIT criteria for EMRs will recognize that there are 3 APIs required to be published as part of certified HIT starting in 2018, and those are consumer-facing APIs. So we started talking about an object, a solution, a bit of enabling infrastructure that if we had with provider directories with regards to direct, maybe we wouldn't have so many obstacles to its ready adoption, at least in some parts of the country. What we're trying to do here is get ahead of that curve and produce a registry for those APIs that will be required as part of the 2018 releases of the EMRs that will be going to market in the beginning of that year. We will also be enabling and registering our consumer-controlled applications and that can interoperate with them in such a way as to create a virtuous circle. APIs need a mechanism to enable trust of the apps that come and ask for data. We're going to support dynamic registration of registered apps to registered APIs, and in effect, reduce the burden on the provider organizations that will be publishing those APIs, and actually reduce the cost of consumer-controlled apps, being able to register with all of those instances of different EMRs being deployed across the country. I was kind of asked by Jeff, and I kind of dragged my feet on coming up with some predictions for the future. And you know, my mom said, "You never talk about something you're not 100% sure about." So I actually dragged my feet until the ONC annual meeting to really think about this, where this slide was shared. And I thought it was very indicative of the future that I couldn't quite figure out how to capture, but I captured with my mobile phone. And I actually tracked down the slide from the deputy, the under national coordinator for Dr. DeSalvo. And I think this really indicates the future that we're all skating towards. And I think we're getting closer and closer to this capability where we have this triangle that includes the establishment of learning health system. The trust harbor that I talked about are the two corners of that triangle on the bottom, where we have data providers, covered entities, publishing data both to consumers and to research. And in the future, we expect to see consumers also being able to directly contribute data, including patient-generated health data, to research. So I bravely plagiarized from our fearless leaders in DC. That's all I have.
As national leaders, Dave and Jitin and Aaron have very modestly and generously gone under their time allotments, leaving me 20 minutes to talk to one slide, but I won't do that to you this afternoon. Before I explain what these acronyms and arrows and clouds and things mean, I'd like to give you a little bit of background. When Commonwealth first started, mostly EHR vendors were joining. Now they have other members like PHRs and consumer-facing apps. And at some point, Commonwealth made a decision to allow 2 statewide health information networks to join, MiHIN for Michigan and the HIE Texas, operated by the Texas Health Services Authority, THSA, not to be confused with TSA. And so Jitin challenged us to come up with some what we then called national use cases. We're calling them interstate use cases now. And so Tim and I got on the phone with George Gooch, who was here this morning. George, are you still here? There's George Gooch. George is the CEO of HIE Texas and THSA, and they have their own sort of water problems in Houston now. And so we started talking about what are the no-brainer use cases, and immunization history forecasts seemed like a no-brainer because out of 64 CDC grants for IIS support, that's Immunization Information System. That's one of the acronyms on the green cylinders that you see in the state departments of health up in the blue boxes. 26 of those support immunization history forecast types of queries where you're pulling immunization history information out of the IIS. And I think another 19 instead of supporting immunization history forecasts, just support pulling the history. And so we said that's a no-brainer because MiHIN is a member of Commonwealth, THSA is in carry quality in Commonwealth. They connect to the EHRs. So the EHRs that you see at the bottom, and you see all of the big vendor names, and there are a lot of other vendors that are not listed, can send queries through Commonwealth or through their connections via carry quality to the statewide HINs, to MiHIN, and to HIE Texas. And we have connections into the state data hubs, okay? In Michigan, it's Rhapsody. I'm not sure what it is. In Texas, in New Jersey, it's Rhapsody. And those data hubs send the queries to the immunization information systems, get the results, and then you take the reverse path and bring the results back out to the EHR. And if you look at all of those little blue and green dots at the bottom and think of those as football fans in Michigan or consumers, using the technology that Aaron explained from Nate, the Nate blue button for consumers, the consumers can then further pull that immunization information from the EHR using direct secure messaging. And what parent, the day before summer camp, would love to be able to automatically get, these ladies, right, you have kids, you're laughing, you want your kid to go to camp, and they call you, and the counselor says, we don't have your kid's immunizations. And you call the pediatrician, and they say, well, you're going to have to drive over because I can't fax it to you, and I can't email it to you. At that exact moment in time, I would pay $19.95 in a heartbeat to get my kid's immunization history to send him away to camp, okay? And so we started talking, well, all of them actually, 3 boys, so all teenagers. And so we started talking to our friends from New Jersey, Van, you met earlier, and Jim Kavanaugh, and Tom Gregorio at the New Jersey Innovations Institute. We're working with them to set up their immunization query capability with their state IIS and the New Jersey HIN, and they said, hey, we want to be a part of this too. So we have reached conceptual agreement to do a pilot for interstate immunization history sharing. And we bounced this off of Carla and Dr. DeSalvo this morning at Kelly Cronin's request. They did not like this. They love this, okay? And so we're going to try to make this go forward and also follow it up with the other acronym that you see in the state departments of health. You see the CLPS. In Michigan, at least, that is a child-lead poisoning system, okay? And that's where the blood lead results are stored. Texas and New Jersey also have lead registries. We said, well, that can be the second interstate use case. Let's get it working with the no-brainer. And we're already talking about other interstate use cases, perhaps Zika or whatever, because in all the crisis management workshop this morning, there was a lot of discussion about what are the things that you can do with public health in a time of crisis or to help prevent a crisis or to respond to a crisis. So I just want to thank Dave and Jitin and Aaron and their national leadership and their positions to be able to connect all of these EHRs and other organizations, consumer-facing apps, you name it, to begin piloting some interstate use cases at Jitin's prodding. Thank you, Jitin, for pushing us in this direction. So we'll take some questions now.
Hi, everyone. So this question is for Dave. Jeff Chin from the University of Michigan Health System. So if I understand Carry Quality right, it's kind of one of 2 kind of big projects underneath the Sequoia project. So there's Carry Quality and there's also the eHealth Exchange. I'm curious if you could talk a little bit about how they might be related. One's a network of network, one's a network. Will there be kind of synergies between the 2 in the future?
Well, there's a fair amount of synergy today, I think, but just to back up a little bit and provide a little background on the initiatives you mentioned. So my initiative, Care Quality, is organized in terms of where its corporate home is under an organization called the Sequoia Project, which is a nonprofit with a public service mission that is really intended to be the home for a variety of initiatives and projects around health IT interoperability. The Sequoia Project essentially provides Care Quality with its corporate services so that I don't have to have my own marketing and accounting and all that good stuff. The initiatives are separately governed. We certainly do collaborate, but the initiatives are separately governed and are separate things. And you alluded to this in your question. The eHealth Exchange has a long history. It was originally developed out of ONC as the Nationwide Health Information Network, originally the MiHIN. They added a W at some point. Now it's the eHealth Exchange, operated in the private sector. And it is a data sharing network. It's one of those communities that I described. And as with the other communities, it sort of has its center of gravity, and it does many things to connect its participants to one another, but a lot of its traffic, the bulk of what it does, and a lot of its historical context centers around connecting private sector entities to federal agencies, specifically the VA, Department of Defense healthcare facilities, and the Social Security Administration for a particular use case they have. So we do anticipate, in fact, the eHealth Exchange governance structure, the coordinating committee, and sorry, this is probably a lot of detail, has approved participation in the care equality. There are several eHealth Exchange participants who are care equality implementers. The HIE Texas, THSA, and Coordinated Care Oklahoma are organizations that participate in the eHealth Exchange, and they're sort of going to share their experiences and are sort of serving almost as a pilot, if you will, for the eHealth Exchange membership in general, in terms of being part of the care equality ecosystem as well.
Hi, Jim Cavanaugh from New Jersey. We've talked a little bit in the last couple of days about patient identity. You're all working on models for sharing data. Are you collaborating with each other at all about coming up with some standard, even a standard demographic set for identifying patients? Any synergy in what you're doing?
I think we all work together quite a bit, actually, on especially patient matching. The concepts that are emerging around a virtual voluntary patient identifier are very important for connectivity across all care settings. An important concept that Dr. DeSalvo touched on with regards to consumer-mediated exchange. You know, the consumer is always the only person that's involved in all of their care. So they, in many cases, can act as the best foreign key correlator to themselves and help facilitate some of the things that just Jitin and Dave are enabling. There has been, and we all kind of shared back and forth different research into that. The HIMSS Identity Management Task Force has made some recent recommendations. ONC has put forward some white papers around the topic that I think are important and seminal, and happy to share those with you as far as, you know, best ways to maximize algorithm success.
Yeah, I agree 100% with what Aaron just said, and I'll just add a couple of other places, just examples of where we've collaborated with the rest of industry. I think the Sequoia project came out with a really interesting paper on patient matching. Was it earlier this year? I don't remember. Time flies. I think it was much earlier this year. And we contributed back what we'd learned through our operations, being a running network as well. We contributed back what we'd learned was working and not working about not just algorithm, but we'd added process on top of it. We'd added something called strong identifiers and others, driver's licenses to it. And we figured out what works and doesn't work when you kind of add those other elements in. So that's one place we collaborated. Then, of course, a number of you know of the CHIME challenge for patient identity matching as an algorithmic problem, and we didn't contribute to that because we didn't have anything unique from an algorithmic point of view to add to that, but we supported the CHIME challenge and we did whatever we could to support the overall initiative, and we'll probably, depending on what comes out on the other side, we'll hopefully be adopting it as well. For us, it's just another important building block towards making a real a patient-centered network to run.
And I would agree with all of that as well. It is a huge challenge. You have a limited set of data that's effective for matching, that is actively collected by the large number of systems that are out there. You can talk about lots of possibilities for data that might feed into a good algorithm, but it all breaks down if it's not actually being collected at the point of care. So there are all those challenges, and they're well known, and we do collaborate, certainly, all of us, in trying to address them. I think Aaron's point about the patient is a good one, where ultimately if we can make it easy, as I was saying before, and we're not there yet, we haven't made it easy by any stretch, but if we get to a point where we have the tools in place to make it easy for patients to actually be the arbiters of where they've been seen and where their records are and who has what and where information is that can be shared, some of that challenge can go away. And I think it's an interesting line of work in terms of making that a reality. That's still a distance off, though, realistically speaking. And so we do need to work with what we have. And that's like efforts like Jitin described, where the Sequoia Project did its white paper, and which is not just sort of a fire and forget white paper that was out there, as his contents or comments implied. We were actively seeking feedback as the Sequoia Project, and there's some ongoing work there to try to fold that into some continued best practices to provide. But in any case, it's a challenge, and I don't think any of us up here have easy answers, but we're trying to be collaborative with one another and work together to be part of the solution.
So no argument here. I agree with the other panelists. And I believe, Dave, it was either the Sequoia Project's conclusion in their white paper, or perhaps it was the National Community of Practice, that one of the primary conclusions was that an additional factor is needed. Was that the Sequoia, or maybe I'm thinking of the Community of Practice? So
That was a conclusion or a recommendation of the HIMSS Identity Management Task Force.
the HIMSS Identity Management.
Yeah.
So in Michigan, we have developed a thing called the Common Key Service, and it's an additional factor to aid in more accurate patient matching. And it's actually in pilot now with a number of hospitals. It is not a key that is exposed to consumers. It's used only to match to MRN numbers and to the state master person index. We're also deploying that in New Jersey, and at such time, should a voluntary patient identifier emerge, we would obviously link the common keys to that, because that would be a key that consumers could actually see in use across a learning health state.
Yes. And you know, the statewide consumer directory has a lot of opportunities to help us enable consumers to track this self-correlated identity across systems as well.
We have time for a couple of more questions.
If you are planning to geek out this today, this is the time to do it.
Hi, my name is Sarah Barden. I'm with the Michigan Pharmacists Association. And this is primarily directed to Jitin. When I was looking at the list of providers that you were connected to, I didn't specifically see where any pharmacies or pharmacists were listed. And I was wondering where that group kind of fits into what you guys have been doing.
Yeah, absolutely. So we have, so pharmacists are an important part. In fact, they're usually sort of an underserved part of the health information exchange experience. Obviously not from a medication prescribing point of view, but more from the point of view of their ability to more than that impact the patient's care. I mean, it is an immense touch point. We have two pharmacy-related organizations who are members of Commonwealth, and they're helping us to drive use cases there. You know, as Jeff implied, you know, some time ago when MiHIN and THSA joined Commonwealth, what I encouraged them was actually, you know, what I encourage every member of Commonwealth, we'll only do what our members tell us to do. We're not going to, we have no pie-in-the-sky ambitions, except that everything should be patient-centered. As long as it's patient-centered, go forth and help us figure out what can be valuable to those that you serve. So two of our members, CVS Pharmacy, who everybody here knows, presumably, as well as Omnisys, who we may or may not know, but they are the HIT platform used by a number of pharmacy organizations, some large, but especially the small ones, use them as their health IT system. And so they're helping us to figure out, well, where is it that the clinical data that you get from a CCDA, how can it get exposed to a pharmacy in a way that's sensible for that constituent group? And you know, conversely, how can the data that they have can come back to us in a sensible way that's useful for providers across the network? So very much first-class citizens of the network. I think this year they will help figure out a use case that makes sense for them. We started in a very ambulatory and acute part of the world because we needed to get something going, and our initial members were EHRs. And so there's a plethora of use cases which I really don't know when they're actually going to hit. Actually, the funny thing is it is really member-driven, but my hope is that there is something pharmacy-related, if this year, if not, then at worst the next year. And it'll be up to them to make it happen.
Additionally, in Michigan, major pharmacy chains like Walmart, Walgreens, Costco, CVS Caremark, and also SureScripts are connected directly to MiHIN, and they submit immunizations into the state MICR immunization registry, and now have the ability to query for history. So for the way our architecture is set up, that would not necessarily need to hop through Commonwealth, but it's directly connected to the statewide HIN.
May I add one thing too?
Yeah, sure.
Yeah, that's absolutely right. There are a lot of places where, and again, it's about doing something that's smart, that's not necessarily duplicative or complementary in some way. Sometimes it is duplicative, but we're not driving it as much. One of the places where I've heard the pharmacies talk about you utilizing Commonwealth is around the other types of equipment, healthcare equipment they have in the pharmacy. Durable medical equipment, for example, is a great example. It doesn't connect to the rest of healthcare, and knowing something about what equipment is being sold to what individual for the purposes of treatment is pretty important. It can be extremely valuable. So that's one of the places where I see them moving to.
Just to build on those thoughts, we came up with the label Trust Harbor for the work that we're doing in the future, in the sense that we're focused on a narrow use case related to regulatorily required APIs that will be part of EMRs in the future to have a target that we have to hit. But our intention and our hope, and I think Michigan will be one of the first states where we're able to move, is enabling consumers to also receive data from network sources as well. And in some cases, picking up data from SureScripts, all those use cases to be defined. But the intent is Nate would like to collaborate with everyone, Commonwealth, Carry Quality, a lot of interest in finding out more about what's going on at Chic, and how that bullet that I caught yesterday would be very aligned with the things that we want to work on with them as well.
Still time for another question.
Nothing hard, come on.
Somebody give us a stumper, come on.
Now you put pressure on.
Or a low ball, we'll hit it out of the park.
How about data across sectors other than health and their influence on the outcomes that we experience? So, honestly, one of the things that I'm really excited about, that I'm learning being here at this conference, is how we'll be able to, families will be able to, hopefully, and providers learn more about, for example, what services a consumer that's receiving health and human services currently has. There's a young man standing up with his hand raised.
Hi. We'll go over here and then over here.
Me first. Hi, Jeff. Carol Robinson, Cedar Bridge Group. Thank you, all of you. Terrific work. Really super excited to see how this develops. My question is about your partners on the bottom of the slide, and knowing how many of those organizations and vendors have many, many things on their development plate, on their roadmaps. They are losing or having trouble retaining the right kind of trained staff in some cases. We work with several of them in implementation projects, and it's mixed, I'll be honest. And so I would just like to, that's an aggressive and important list of vendors at the bottom of the page, and I'd like to have your thoughts on how to get them behind this as a priority in relationship to all of their other priorities they're working on.
It's a great question. I can go first, and certainly welcome Jitin's response too. From the care quality perspective, I think this for us is a conceptual thing at this point. It's relatively early stages. What's shown in the diagram is, again, conceptual, what is possible through the care quality framework. It is not to imply that any of those organizations named there have, in fact, signed on to do this. And I think that is important to know. That said, I think as we have the support for doing this as we work together to really understand the use case. And there's a fair amount of detail work that needs to go into making this more than a concept. As we do that, I think we'll want to do that in a way that makes it easy or relatively easy for everyone to support. And I think if there truly is an emerging cross-states, multi-states standard that's being developed and mechanism for exchange, I think you'll start to see folks fall behind that. But we do need to make sure that we're crossing the T's and dotting the I's as far as really fleshing out the use case before we can make that happen.
I think I actually absolutely agree with what Dave just said. I'll add in a perspective that, maybe three things you kind of want to think about. One is getting these organizations to kind of synchronously or with relatively little asynchrony work together on getting some sort of standards organized such that they can actually implement use cases and then we actually have a working network. On that level, we do what every other organization does. We have a product planning process, a product management process. We have a prioritization process. All member companies tell us what FTEs and time they can donate to making this happen and what their time bandwidth looks like over the year. We go, every quarter we see if our product roadmap is on schedule or not, and we adjust based on the feedback we get both from our clients, and the end clients, the end users, as well as from my members, the HIT vendors themselves, to figure out if we're on track. So there's some amount of product management that helps with that a bit. The second part of it is there is definitely some amount of training that needs to happen on client side for them to understand how to utilize services, like what comes out of Commonwealth. But the biggest part is not the mechanics. The biggest part is actually just the psychographic change, because doctors are so used to being beaten down now that they don't think they can get the data. How many times has somebody knocked on their door and said, we're connected to X, or we're connected to Y, or we're connected to Z? You can get the data, and they go to the portal, the separate portal in the middle of their clinical process to try to connect to X, Y, and Z, and there's nothing there. So at this point, some point in time, they just say, well, F this, I'm just not going to try. Because honestly, there's no data there. I'll ask the patient what I can get from him, and whatever I get from him is what I got. And then I'll continue from there, because I have 15 minutes and 500 patients in my panel. So that's the end of that. So there is some amount of training, but it's actually largely a cultural shift as opposed to a mechanical training. And then the third thing to think about is we love to spend a lot in healthcare. You need to connect two sites together. Let's build an interface. Let's get a bunch of people to work out on a standard. Well, we should start out with this massive HL7 spec that was built like 30 years ago, because that's what ONC tells us to do, even though I can probably create the standard in 10 lines or less. But that's what we should do. So we'll do that. We'll pay a bunch of developers a bunch of money so we can connect our two sites together. Oh, we need to do analytics. Well, let's build a data warehouse, because obviously that's not available on Amazon Cloud. And go ahead and spend like another few $100,000 doing that too. Oh, we have to train people. Oh, we have to hire like a massive army of consultants to go teach these people. What about the Google approach? What about, here's a search page, there's a bar in it, and there are two buttons. What happened to that? That's where we need to get to. So you kind of have to do both, because it's not as simple as Google in some ways, but it's also not as complex as we make it out to be. That's why when I put up the workflow slide, that's 4 steps. It's really just 4 steps, but that's too much already. I need to automate the crap out of that so that it's just no steps. You just get insights at the point of care. But it takes work, but it takes the right mentality to say that that's what we need to get to, not more and more of the same. Let's overinvest in something which is going to change change overnight.
We're actually in overtime, but there was a gentleman waiting over here. If you could please, no, it was a great answer. I loved it. Make a quick question, and then one panelist give a quick answer, please.
Yeah, I think it was answered mostly, but are there any prerequisites to join your Commonwealth other than being a healthcare delivery provider or a vendor?
I think that's mine. No, see, as long as you are an organization who believes in the mission, then you have a chance to join Commonwealth. We have an agreement that you obviously look at, and then if you want to subscribe to services, we have a set of data policies and other governance-related things which you need to look at so we know that the right things are happening on the network. Nothing too much fancier than that. So that's really all it takes. So our smallest organization is a 6-member startup. Our largest organization is like CVS, obviously, or Cerner. So all sorts of organizations have found a way to easily participate in Commonwealth.
Please help me thank our national health information sharing leadership.